Hello and welcome to MUSC Hollings Cancer Center Crosstalk. My name is Dr. Marvella Ford. I am the Associate Director of Population Sciences and Cancer Disparities at Hollings. And we are thrilled to be joined today by Dr. Craig Lockhart, the Chief of the Division of Hematology and Oncology in the MUSC Department of Medicine. He's also the Associate Director for Clinical Science at Hollings and the Chief of the Oncology Integrated Center of Clinical Excellence at MUSC Health. Dr. Lockhart, thank you for joining us today.
Thanks for having me.
Today we would like to get back to the basics and talk about what cancer is, how it grows, and what people should know. If you have a question during our discussion, please leave your question in the comments section. Let's begin. Dr. Lockhart, what is cancer?
Cancer is when we have an abnormal collection of cells. We have normal cells in our body, and sometimes through various means they start growing abnormally. And if they're growing abnormally, some of those cases it can be benign. But if the cells are growing abnormally and they're causing a real problem, that's when we usually define them as some type of cancer.
How does cancer start? What makes these normal cancer cells suddenly these normal cells suddenly turn into cancer cells?
There can be a variety of different reasons why that can happen. Some of us have genetic predispositions to develop cancers. Some of us, we are exposed to different things in our lives like smoking or other environmental concerns. And sometimes it happens for reasons that we just don't understand.
We hear a lot about stages of cancer. What does it mean to have a stage 1 cancer or a stage 3 cancer? What do these different stages of cancer mean?
The different stages of cancer means basically how far has the cancer gone. How big is the tumor? Has the cancer spread to lymph nodes? Has it spread beyond the lymph nodes? And in general, the staging tells us how somebody's going to do. What is their overall prognosis? How well will they respond to different therapies? In general, the earlier the stage of the cancer, the easier it is to treat, and the more likely that the patients will have a good long-term outcome.
How many stages of cancer are there?
In general, there are 4 stages for most cancers, but several of those stages, stage 1 can be broken down into several smaller substages. Stage 2 also broken down to several smaller substages, but in general, we talk about 4 stages for most cancers.
So it sounds as if you're saying if you're diagnosed with a stage 1 or 2 cancer, your prognosis may be better than if you're diagnosed with a stage 4 cancer. Is that correct?
That is correct, and that's why screening for cancers is so important, because we tend to find cancers at an earlier stage when people are involved with their health care and are undergoing cancer screenings that are recommended.
When we know screening is such an important part of early detection for cancer. Speaking of screening, that gets us to another question. We have seen in South Carolina and across the country that the rates of cancer diagnosis and death are much higher in African Americans or Blacks than in other people. What are some of the reasons for this?
So, Marvella, there are several reasons for that. Number one, in our community, we're not the best at having cancer screening. We need to improve upon that. Number two, even when patients are being screened, there are some genetic components that we don't fully understand yet why some African American patients have worse outcomes than their non-African American counterparts with certain kinds of cancers. And we're still investigating all of those things. Some of those things seem to be genetic, some things may be environmental, but we need to work all those things out to find out why these differences in outcomes are happening, because this is very important.
So screening is very important for African Americans or Blacks, and for all people, but especially for African Americans or Blacks. Do members of this group tend to have lower screening rates than others?
It tends to be along community lines. It depends. A lot of it tends to have to do with location. But yes, in general, and in South Carolina in particular, we do have lower numbers of patients having the appropriate screening that they should be having.
Dr. Lockhart, in your own practice, when you see African American or Black patients and white patients, do you see that the Black patients tend to be diagnosed at higher stages of cancer than the white patients?
Personally, the kinds of cancers that I see are gastrointestinal cancers, and in general, those cancers tend to come along at relatively high stages compared to some other cancers, because in things like pancreatic cancer and esophageal cancer and stomach cancers, we don't have screening programs. They don't exist in this country. And because of that, I can't say that I'm seeing stages that are higher for African Americans compared to their non-African American counterparts. For things like colon cancer, I do get a sense that the patients that I'm seeing, the African American patients that I'm seeing with colon cancer, generally have a higher stage. But again, my only experience is anecdotal, but we do know that nationally we do see those trends. Personally, I see it, but it's hard for me to say personally how it is, because again, I'm only seeing a small slice of the population.
You're really pointing to the importance of looking at data across a health system or across a state or across a nation. So Dr. Lockhart, you are a medical oncologist.
Correct.
What are other types of cancer doctors, and what do they do? And what do you do?
What do I do? Medical oncologists, well, in general, there are sort of three types of cancer physicians that we tend to have. We tend to have surgeons or surgical oncologists, so they're involved in removing of the cancer through surgical means. Radiation oncologists, who can treat the cancers with radiation therapy, and medical oncologists like myself are the doctors who administer chemotherapy. Sometimes it's chemotherapy by vein, sometimes it's chemotherapy in pills, sometimes it's targeted therapy in pills, and the hot thing being immunotherapy. Sometimes we are the ones also administering immune therapy medications as well.
So let's turn our attention slightly from clinical care to clinical trials. We use that word a lot. So I guess the first question is, what are cancer clinical trials?
So everything that we do in cancer, including the ways that we screen for cancers, the way that we treat cancers, all of it came from clinical trials or clinical research studies where patients participate to find out, what's the best way to screen for a cancer, what's the best way to treat cancer. Everything that we take now for granted, things like colonoscopies, things like some of the common chemotherapies that we give, or some of the other treatments that we give, all of these were developed through clinical trials. So they're really, really important to help us establish what is going to be the standard way that we treat cancers.
It sounds like a lot of the care that patients receive today is the result of previous clinical trials. So we're very grateful and thankful to all the people who participated previously in trials to make treatments better for patients today. Dr. Lockhart, why is it important to have racial and ethnic diversity in cancer clinical trials?
This is very important, Marvella, because a lot of the clinical trials are conducted and completed in sort of larger cities and in cities, especially in the United States, mostly in the Northeast and on the West Coast. And they tend not to have a lot of patients with racial diversity. And so because of that, we don't 100% know that some of the conclusions that are drawn from these clinical trials are actually universal, in that, yes, we're seeing this particular result, but because of the homogeneity of the population that's enrolled in the clinical trials, we don't know if those same results that we're seeing in those clinical trials are actually applicable to the entire population. So it's really important that we have a diverse population of patients and people undergoing screening participating in clinical trials, so we have a better idea that these results are actually generalizable to the public.
Dr. Lockhart, you have so many different roles here at the Hollings Cancer Center. Can you tell us a little bit about your role as a medical oncologist? You talked about that a little bit, but you're also the chief of the Division of Hematology and Oncology, and you're the Associate Director for Clinical Sciences at Hollings, and you're the chief of the Oncology Integrated Center of Clinical Excellence at MUSC Health. So can you tell us a little bit about your roles and how they interrelate?
We could talk for a long time about my roles here and how they interrelate. In general, to try to summarize things in as succinct a way as possible, here at Hollings, we are the cancer center of record for the state of South Carolina. We're the only NCI designated cancer center in the state, and probably will be for a long time. Because of that, we feel a certain sense of responsibility for cancer care for the entire state of South Carolina, all the citizens of South Carolina. And so in one capacity, my role as what we call the ICE chief is to have thoughts about what we call the cancer service line. How is cancer delivered not only in Charleston and to the MUSC immediate community, but also throughout the state? So that's where that role comes into play. The second role in the Hollings Cancer Center involves the oversight of the clinical research enterprise. And again, and a lot of us believe, not just me, that clinical trials are the best way to deliver cancer care because we're learning new things, and for a lot of different kinds of cancer, that's the best way to treat patients is under some research study because we just don't know the best way to treat these cancers, and the current standard of care is just not acceptable. And so my role at the Hollings Cancer Center, as far as the clinical trials enterprise is concerned, again, is to make sure that the citizens of South Carolina have access to the latest and most innovative cancer care, not just standard, but also, the research studies that are ongoing. And the third part is the chief of hematology oncology, and a lot of it is recruiting doctors into our system that can deliver the kind of cancer care that we want to deliver through MUSC, and also making sure that the patients of South Carolina have access to top-notch doctors in the field who can deliver the kind of care that our citizens deserve.
And what is your vision for MUSC Hollings Cancer Center? You've touched on it a little bit, but could you talk about it a little bit more?
So the vision would be that, again, we are the cancer center of record for the entire state, and so we need to deliver quality cancer care across the state. We start with Charleston and we kind of fan out from there. We do have a lot of relationships with other cancer centers in the state, and we are partnering with them for routine care, and we're also partnering with them for clinical trials to make sure that patients have access to these novel therapies and these novel treatments. And so that would be the vision, that we elevate cancer care across the state and we provide Hollings quality research access to all the patients across the state, not only with treatments, but also with diagnosis and just access to care overall.
Thank you so much, Dr. Lockhart. And one of the benefits of being a National Cancer Institute designated cancer center is that we have access to clinical trials that other cancer centers just won't have access to. So we're able to offer our patients trials that are offered at other major cancer centers across the country that they would not otherwise have access to. So we're so delighted and thrilled to have you here at the MUSC Hollings Cancer Center with all that you bring for the Cancer Center and for the people of South Carolina. Thank you so much, Dr. Lockhart.
Thank you, Dr. Ford.
Thank you so much for joining us for Hollings Crosstalk. We welcome and invite your comments. Please be sure to share your comments with us. Thank you.